Okay, so basically with hypersensitivity or allergy responses, something that we're gonna kind of come that comes up next is these IgE antibodies. And these were actually mentioned when I talked about asthma a long time ago with your respiratory drugs. And that's because your IgE antibodies control your allergy or your those mediated responses. So asthma is an allergen like induced response, right? Something triggers your asthma, and that's why you get like an asthma attack. And the reason I bring that up is just to help better understand what IgE antibodies are and how they work in terms of allergies. So, the same way asthma releases these IgE antibodies in response to some sort of allergen or some sort of environmental stimuli, um, we get IgE antibodies in response to allergies. So, basically, allergies are just an inappropriate and usually a harmful response to the immune system. And what happens is, like I said, those IgEs are released and they trigger your mast cells and your basophils, which are just a fancy way of saying that you have the other cells that are released and they also mediate the allergy response. And that causes some sort of reaction, right? Like I sometimes get something called contact dermatitis. And when I touch certain soaps or I wash my hands, I get like red dots or like little hives all over my hand. And that's all because of this really crazy process. And hypersensitivity is when the immune system overreacts with excessive inflammation in the presence of some sort of antigen. So you're exposed to something and your eyes might water up and they become itchy and you're sneezing. And this is your body's way of trying to fight whatever sort of allergen you've come in contact with. And it could be life-threatening because these allergic responses can turn into things like anaphylactic shock or angioedema or even bronchoconstriction and possibly circulatory collapse. So that is why it's really important for babies or anybody to get tested for allergies, or if they start getting responses to different stimuli that they never had before, to get tested because they can be life-threatening. So ways that we can diagnose hypersensitivity or allergens is IgE. We can give an eosinophil count, which those eosinophils also mediate that allergen response. And they might ask you on your med surg exam, a patient comes in with itchy, watery eyes, and they said they were exposed to, I don't know, let's just say pollen. And what can the nurse suggest that they do in order to see if they're having an allergic mediated response? Well, actually, a skin test is one of the most accurate tests that you can give to test for an allergic reaction. And they could do that through an injection or like superficial on the surface, touching your skin with those things. So, those are just different ways that we can diagnose like allergies and hypersensitivity. Um, so another important thing about allergies that's also NCLEX related is that allergies should be on every patient's medical record and they should have an alert bracelet. Anybody who has like severe allergic reactions, like some people are allergic to peanut butter, and as soon as they eat it, their throat swells and their face swells. They should have an alert bracelet on to notify people, especially medical providers, that they have severe allergies. That can most definitely be on your exam as a select all that apply as what sort of patient education should you teach your patient regarding allergies, and that they should have an alert bracelet. Other things include that inflammation occurs in 5 signs, right? So, how do we know if they're having an inflammatory response to the allergens? Well, if they have warmth, pain, swelling, loss of function like numbness and even redness, that can indicate signs of inflammation and be related to an allergy related response. And most importantly is as a nurse, we want to have a comprehensive allergy history and a thorough physical exam so that we have the appropriate data that we need to diagnose and manage allergic disorders, right? Because, for example, when I was in the hospital, I had a patient who was allergic to penicillin, and penicillin is related to cephalosporins. Cephalosporins and penicillins are like cousins. they have very similar properties. So if you're allergic to one, you can most definitely be allergic to the other. And according to the family, if this patient has penicillin, they might swell and have angioedema and they might have anaphylactic shock. So thankfully, the Epic system said that there was an alert for this medication and to ask the provider before administering because it was a cephalosporin and we did not administer the medication because it would have caused a severe reaction in that patient. So that's where all of those alert bracelets, it's really important for that because, computers can make errors, so we want to have as many checkpoints as we can as a nurse. Now, I saw in your notes that you have different types of hypersensitivities or different types of responses that your body can produce in response to an allergen. So we have an IgE antibody reaction, which is the typical for a type 1 sensitivity. And as I said, IgE kind of mediates everything. It's a type of antibody that reacts when it sees an antigen. So common allergens, this is like more or less an immediate rapid reaction that you get. Okay, this is like someone who has type 1 hypersensitivity and someone who has like a food allergy to like peanuts. Okay, because it's going to happen as soon as they eat that. And very shortly, they're going to have symptoms of an allergic response. These include, like I said, inhaled like pollens or fungal spores, anything in the air, dust dander, ragweed, ingested like foods or additives or drugs, injected venoms, drugs, contrast, and other things like that. Now, in like I said, type 1 means it's rapid. So we're going to have a rapid response. And the most adverse reaction that we can get in these type 1 is anaphylactic shock or anaphylaxis, which is when those blood vessels dilate, there's a decrease in cardiac output, they have bronchoconstriction or they're having trouble breathing, they have hypotension because of the vessels being dilated, they have angioedema or swelling in the face and the throat. They could be flushed. The redness is from that dilated blood vessels. And urticaria, which means hive. It's just a fancy way of saying hives. But on the NCLEX, they're not going to tell you that. So it's really good to be able to identify your terms. So nursing considerations, as I mentioned already, a patient should wear a medical alert bracelet that says, hey, they have an allergy to this. Those patients should always carry an EpiPen with them. Why? Because if they have an allergic reaction, we want them to inject the EpiPen into the side of their leg because that could save their life and reduce that bronchoconstriction and reduce that angioedema. The patient's family members should also know how to use it because God forbid the patient, can't find the EpiPen or they dropped it because they were having so much trouble breathing, somebody around them should know how to use it. And we want to observe for signs like bronchospasms, hives or urticaria, and shortness of breath. So, like I said, this could be a select bullet apply. What should be some nursing considerations for a patient who has an allergic response? Have them wear a medical alert bracelet, carry an EpiPen. Family should know how to use it and monitor for signs for anaphylaxis or even teach patients and families signs of anaphylaxis. Now, angioedema, like I said, involves all the blood vessels and layers of the skin, mucous membrane. So just imagine swelling everywhere, especially in the lips, face, tongue, and neck. That's why it's so scary, angioedema, because it's affecting this upper part where we get our breathing, how we breathe, right? If our throat is closed in, we're not going to really be able to breathe properly. So that's where anaphylaxis and angioedema, they can go hand in hand. You could have an anaphylactic shock, bronchoconstriction, and you could have angioedema swelling in the face, lips, tongue, neck. Now, things like that is, remember I said those ACE inhibitors for hypertension can cause angioedema and a dry, nagging cough. So if a patient says they have a dry, nagging cough and they have swelling in their face, you want to stop. We want to hold the ACE inhibitors like enalapril, lisinopril, and call the doctor immediately. And we want to notify the doctor, but before we even get to notifying the doctor, in this type of reaction, if they're having severe bronchoconstriction and angioedema and they're having trouble breathing, we're calling a rapid response team. They need to be intubated immediately because airway is the priority here, and their airway is being obstructed from the swelling. So these are the types of situations with anaphylactic and angioedema where we may need to call rapid response team, and that should be one of your options. If it says that this patient's having swelling in the face and the lips and they're having trouble breathing, call the rapid response team. That's what you should be doing. Now, we also have type 2 or cytotoxic reactions, which means that your own antibodies start to attack your own immune system. And this can happen when you have like a problem with blood transfusion, right? So if you give maybe an O negative blood type with an A blood type, right? Because an O person can't receive anything other than O. So if they were to receive something like A, they're going to have a blood reaction, okay? Hemolytic disease of the newborn is basically like a rejection of the blood cells when they're born. And that usually happens when something called an RH factor happens, and the mom's positive and the baby's, no, the mom's negative and the baby's positive, I think. I always get that confused, but nonetheless, the mom and the baby are opposites. And because of that opposite reaction, they can have something called hemolytic disease, and the blood vessels, the blood cells just start like bursting because of the reactions of between the R negative and the R positive. They don't react well together. And certain drug reactions. Type 3 means that we have some sort of excess antigens, okay? So we have these really complex antigens, they form in the blood. It's usually an autoimmune. So autoimmune means affecting my own immune system. And an example is rheumatoid arthritis, because rheumatoid arthritis is not like regular arthritis. It's when your body is actually affecting those cells in the joints and causing that swelling and causing that pain. Hypersensitivity type 4 is a delayed type, okay? So this is what happens when you are exposed to some sort of trigger, but it doesn't happen right away. It can occur hours or even days after exposure, which is very scary because imagine, right? This person's allergic to peanut butter, right? Example, peanut butter. And they don't have a reaction right away. And all of a sudden, right, maybe 5 hours after eating peanut butter, their face starts swelling and they look pale and they can't breathe and they're choking. That's really scary, right? If my patient is having a delayed reaction to an allergen. So that's what type 4 means. It means it's delayed. Things that include that is contact dermatitis, hypersensitivity pneumonitis, or hepatitis. They are delayed reactions to allergens. Okay, so that's really scary. Um, Now, I already mentioned that angioedema and anaphylaxis are that type 1, meaning they're a rapid response to an allergy. It's going to see it immediately. They're going to have swelling very, very quickly. That's why it's very serious, these things that you know about, because this is like emergency management. This is more than just priority. And think about the NCLEX. Your NCLEX exam is going to test you on safety. You can get a lot of questions wrong on the signs and symptoms of different diseases. That's okay. But if you have a question about angioedema or anaphylactic shock, and this patient comes in and they can't breathe, and your priority isn't to ensure the airway or call the rapid response team, we have a problem. So in these situations, when the throat closes in, yeah, we might want to notify the provider. The best way, though, is to call the rapid response team. So as I said, angioedema, ACE inhibitors, I've mentioned this before. ACE inhibitors can cause that dry, nagging cough and angioedema. If that happens, we stop and hold the ACE inhibitors, and we try to get airway going, right? Maybe try to give them some oxygen. But the priority is if they're having that swelling and it's really bad, we have to call the rapid response team. Physical exam findings that might key you in to know, should I call the rapid response team? Are they having lip swelling or itching or feeling in the back of the throat, right? Their face is going to be really, really firm and swollen, and the lips and tongue, okay? They're going to be really puffy. It's going to look like a Botox gone really wrong, okay? Really swelling. Difficulty speaking or drinking, nasal swelling. If they're showing these signs, they really need the rapid response team so they can intubate them and get airway getting into them as fast as they can. Also, like I said, if it's drug induced, we're going to hold the medication. We're going to call the rapid response team and then notify the provider. We will also be administering to them diphenhydramine or antihistamines. Why? Because it's inflammation. These are inflammatory mediated responses, and antihistamines are anti-inflammatory responses. So that is why we give it. Then we have anaphylactic, right? Very similar in terms of you could have angioedema as well, but some things that we might also have with anaphylaxis is that they might not happen right away, right? They they might have feelings of apprehension or weakness, impending doom. The reasons that they're feeling these, it's the same reason why you see it in pulmonary embolism and things like that, is because they are having poor circulation of blood, and they're also having poor oxygenation in their blood. So if they're having poor oxygenation, that means they're having more CO2, and that's causing those feelings of impending doom. They're going to have shortness of breath and dyspnea, hypotensive because it vasodilates in anaphylactic. That's why we give EpiPens, because EpiPens vasoconstrict and help with relieving these symptoms. They could also be diaphoretic or really sweaty, and they can also have pallor, okay? Or which is pale in the face. So we want to promote their health, and the best way we could do that is through prevention. They need to avoid their allergies, okay? Sometimes the NCLEX might be tricky and say that this person has, really bad allergies, but they're always going outside and ragging the weeds, but when they come back inside, they feel shortness of breath. We should probably tell the patient to avoid doing that, okay? Things like that could trigger an anaphylactic shock and could be bad. As I also mentioned, you must wear a medical alert bracelet. That is definitely going to be on your exam. It could be a select all that apply, but for anybody who has allergies, they should have a medical alert bracelet. That lets medical providers know that they have an allergy to X, Y, and Z. Okay, and providers need to know, because if we don't know what they're allergic to, we might trigger it again. They should always, always have an epinephrine or an EpiPen with them. I already said this already, but it's just so important to know that they should carry an EpiPen with them, and that the patient should know how to use it, and anybody else that sees this patient and person regularly. Typical injection is 0.15 milligrams or 0.3 milligrams. Health records should always show allergens, and make sure we have precautions, right? Priority for angioedema and anaphylaxis is stabilizing the airway, okay? In this situation, if let's just say they're taking an IV drug, right? They have the example I gave with the penicillin and cephalosporins being cousins, and that patient having severe allergic reactions to penicillin. Let's just say we gave them that cephalosporin. They might have started having like dyspnea, shortness of breath, and in that rate, if they're really, really struggling to breathe and it looks that bad, we're calling rapid response team. Okay, so in these situations, if it's saying they're having dyspnea, really short, like shortness of breath, swelling, they're hard to speak, it's hard to swallow, we need to call rapid response team because that airway is closing. We also want to get them oxygen, right? But if we had to go with priority and we're looking at the situation based on their symptoms, we're going to call rapid response team. If it's not as bad, we'll give them oxygen, notify the provider, give them EpiPen, and we could also give them, like I said, diphenhydramine, because it's an antihistamine, and all allergen-mediated responses are histamine-based or inflammatory or allergen-mediated responses. So diphenhydramine is an antihistamine and will help reduce the inflammation and help with the airway. But it's going to take a little while for this to occur. So the airway is closing in. So we need to make sure we get the rapid response team if it's that bad. Is there any questions about angioedema or anaphylactic shock? No? Okay. So something that I saw in your notes was also allergic rhinitis. So it's another type of allergy response. It's not as severe as anaphylactic or angioedema, but it's basically like a little cold, right? Nasal congestion, sneezing, throat itching, and that's in response to some sort of allergen. It is a type 1 hypersensitivity, so there is always the risk of anaphylaxis, but normally it won't occur. But like I said, if there is a chance, right, this patient's having shortness of breath, they're really struggling to breathe. It's not like these little sneezing, itchy, watery eyes, things like that. Then we might call rapid response team. Okay, so we have to see in terms of priority what's going on with our patients. So we want to assess, we want to have a good allergy assessment. We want the subjective data, which is how they feel, how they felt before, how they're feeling now, right? How are these symptoms? Because hay fever, also called allergic rhinitis, means that they're usually seasonal. So what sort of things is normal for them to get, okay? And like how they feel, because let's just say they normally just feel a runny nose, but now they can't breathe. They might have been exposed to more of it or something happened, and they might be going into anaphylactic shock. Okay, so we need to also understand what sorts of changes that they have seasonally, because allergic rhinitis is usually a seasonal, like allergy-mediated response. So complications, anaphylaxis, impaired breathing, and maybe non-adherence to therapeutic regimens. Sometimes people need to take allergy medications more frequently to help reduce symptoms. Priority for all of these mediated allergy responses is improving airway. And if airway is not the problem, like an anaphylaxis, then improving breathing, okay? So we want them to reduce allergens, reduce exposure, make sure they take deep breaths and cough frequently. Once again, everything I think seems to repeat, but patient education on minimizing their allergens, using medications appropriately, keeping up with their doctor's appointments, and things like that. Is there any questions before I go into chapter 32? Okay, so now we're going to get into something a little different. We kind of spoke about before how in allergies or allergy mediated responses, it's an immune response, right? It's antibodies, it's your body's different immune cells sometimes fighting against itself and responding to the environmental stimuli like dust, dander, food, whatever. Now, in this chapter, or 32, we're talking about HIV, which is also an immune-related problem, okay? But HIV and AIDS can sometimes be interchangeable. They're not the same, but the reason they can be used interchangeably, and that's why I was noticing through your slides, it might say HIV/AIDS, is because when you get HIV, it leads into AIDS, especially as the disease progresses and there isn't any sort of preventative measures, it will lead into AIDS, and I will get into why. So these are all autoimmune problems, okay? Because it's the body's fighting against a viral infection, but then what happens is the viral load becomes too strong, and then their body starts fighting with it too. Okay, so we have HIV or human immune deficiency. There's something wrong with our immune system. And then AIDS is acquired immune deficiency, and that is from HIV. Okay, you don't just get AIDS, you get it through HIV because it has to start off, and it's a long process. It doesn't happen right away. Okay, so immune deficiency can also be from like medical treatments or infection, but HIV is, as we'll go into, is caused by certain things, and how you obtain it is through certain methods of transmission. So just as the pathophysiology, so that you can better understand HIV, is that HIV is a family of these lentiviruses. It's basically a retrovirus. A retrovirus means that it doesn't take its form inside DNA, it actually goes into the RNA. So it messes up the genetic information in your RNA. And the problem with that is once it gets into the RNA, it's able to trigger these CD4 plus receptors. These are cells that help with the immune response and keeping our immune system strong. And once those HIV or those viral cells attack these CD4 plus receptors, they affect our T lymphocytes, our monocytes, dendritic cells, brain microglia, which basically just means that these cells affect all of the other cells that protect us from different antigens and viruses. So these cells are targeting that, okay? So in summary, as I wrote here, HIV affects RNA and targets receptors found on crucial cells that protect our immune system. Now, HIV can be in 5 stages. I do not believe they will ask you on the 5 stages, but I want you to understand how it works, okay? So here's what happens. HIV usually, you get infected, which is stage 0. You get infected, but you're not going to see any sort of lab effects. It kind of stays latent for a while. It doesn't show anything, and it usually starts as asymptomatic, okay, in those very first stages. So that's also a problem with HIV because you can't detect it early. Stage 1 is primary and acute. It's basically the period of infection with HIV to the development of HIV-specific antibodies, which means now labs can start seeing that there's a problem, that these CD4 T cells start dropping, okay? They normally are 500 to 1500, but then they start dropping from that level. Then they drop even more in stage 2 to 200 to 499. Then they drop even more in stage 3 to below 200, which is when they get AIDS. Okay? Because AIDS is when the immune response is so low that it was acquired from the HIV, and now they're in AIDS. Okay? And unknown means there's no information on the CD4 T lymphocytes or percentages. But the main point is that these HIV virus cells attack these CD4 cells and they make everything lower. All of those immune responses get drastically dropped. They get dropped so low that you go into AIDS. That's why HIV and AIDS are related, okay? So, as I said, very important. It's very important to know that in the first stages, in the very, very beginning, they're going to be asymptomatic, and that can be on your med surg exam, right? They could say a patient was, um, you know, exposed to someone with HIV, and within the last few months, and maybe they have a viral load of like 500, right? They may still be asymptomatic or maybe experience a skin rash, but they're mainly asymptomatic in the beginning. So that's also why it's harder to diagnose patients with HIV in the beginning. Later stages is when we get into AIDS, okay? Because when we start getting closer to that viral load decreasing and causing all of our immune cells to decrease in responsiveness, we start getting into more symptoms and manifestations of AIDS. And this includes things like respiratory manifestations, right? So shortness of breath, dyspnea, cough, chest pain. They're going to have GI problems. They're going to have loss of appetite, nausea and vomiting, diarrhea. They're going to have oncologic or cancer-like symptoms, and they might develop something called Kaposi sarcoma. I put a picture here so that you could better see it. So it's a disease in which cancer cells are found in the skin and mucous membranes that line the GI tract, also the mouth and the anus, and they kind of all these like dark patches that kind of go around the skin. That's an indication that they have AIDS, okay? It's getting to the point where they're getting a cancer of the skin because their immune response is so low. They might have neurologic manifestations, so mental status changes is something that we want to watch out for. Also depression and apathy. Apathy is like loss of emotional responses. Skin changes, they might develop herpes, and they also have gynecological manifestations. So they might have genital ulcers, okay? They might have recurrent vaginal candiditis, right? They're going to have recurrent infections because their immune response isn't as good because it keeps decreasing as you have HIV. Sadly, there's nothing that we could do to cure HIV or AIDS. We just want to try to take early actions to prevent it because prevention, early detection, and ongoing treatment are really important for managing HIV. So we want to teach our patient how to eliminate and reduce these risks associated with HIV and AIDS. And PLWHA just stands for person living with HIV and AIDS. Now, HIV is transmitted in body fluids that contain things like blood and blood products, seminal fluid, vaginal secretions. It can be sent to the mother and child through amniotic fluid or breast milk, but it's not through normal contact. Okay, so if you're talking to someone and they have HIV, you're not going to get it from them. Okay, if you're sharing needles with them, maybe, right? If you're having sex with no barrier contraceptives, you have a higher risk of catching HIV. Okay, so with these patients, right, if it's transmitted through blood products, what do we want to teach them about? Injection practices. Okay, what do we also want to teach them about? If it's secreted through seminal fluid and vaginal secretions, using barrier contraceptives, right? What else should we teach them if they're planning to be pregnant or become pregnant? That they need to be careful that it could transfer from the mom to the child, okay? And breast milk, so no breastfeeding. And we want to be careful with procedures that might cross amniotic fluid through the placenta. And sometimes that could happen when you do certain diagnostic procedures, which I'm not going to really get into too much, but that just becomes really important to know. So education is very crucial with these HIV patients or just preventing HIV in general. So as I said, barrier contraceptives, pregnancy teaching, precaution with blood products and needles. They should have HIV testing. They should have linkage to treatment and care. Consistent and current use of condoms. And it says in chapter, I don't know where, but in your chart 32-4, I would know the correct use of putting on a condom because that could easily be a question because that's important in knowing how to prevent transmission of HIV. Male should be careful with the circumcision, female condoms, take as many precautions as we can. Okay. We also have a harm reduction framework, right? Looking at the needles, right? They should not be sharing needles. That's the main point. Do not share needles. Okay. And you should use bleach to clean needles and syringes used by HIV patients. reproductive education, artificial insemination so that we don't spread HIV to potentially a future child, assisted reproductive technology or ART, so we might have them, maybe do a different route of having a baby, and refrain from breastfeeding, okay? And LGTB are one of the highest risk population groups for HIV, and we want to remain non-judgmental when we're educating them about prevention. So reducing transmission for healthcare workers, right? We really have to be careful with needle stick injuries, right? We really have to be very careful with that and making sure we do those properly so that we don't get sick as a healthcare worker. Standard precautions, because they're not infectious. They can't spit on you when you get it, okay? You have to get it through, like I said, blood products or, sexual intercourse. So no, we don't have to worry too much about that. Always hand hygiene, because that's going to help if there's any sort of blood products that got on our hands or vaginal or seminal secretions. We want to wash that off. And for post-exposure prophylaxis, I would really know this, is that antiretroviral medications should be given within 72 hours of exposure. So if somebody was exposed, they must take antiretroviral medication. This should hopefully help get rid of any HIV before it starts, okay? That's the goal of it, to hopefully prevent it from happening. Because like I said, it stays latent, it doesn't happen right away. So if we could take something, it might help prevent it from actually happening. And they'll take 2 to 3 drugs prescribed for 28 days to also make sure. So HIV is very serious, okay? Antiretroviral therapy, like I said, the goal is to suppress HIV replication so that they do not have HIV. But sadly, it's hard to stop it from coming. So we hope that if we give them this and they do get HIV, it keeps it so latent that they don't really have any sort of prolonged duration of symptoms, and reduce, getting into AIDS and increase the quality of life. But it's just very hard with HIV, okay? So you just have to really be careful with even yourself and other patients, because this is very serious. It can be spread very easily and there's no cure. We can give the retrovirus and hope that if they did get exposed to this and it did, that it would keep it suppressed or maybe even prevent it. But most of the time, once you get exposed, you're more than likely to get it, okay? So that's why we need to take preventative measures, and that's the most important part of the education. So thinking about all of the manifestations, it affects almost every system, right? So we want to look at their respiratory, their nutritional, their neurological, mental status changes, fluid and electrolytes, right? Blood lab values, things like that, okay? And any sort of risk factors, right? If they are a part of the LGBT community, right? That puts them at risk for potentially contracting HIV. And we also want to assess their knowledge level. That's always important I would say, as looking at questions, if they ask you about what should I do first, you should assess their knowledge level and also assess if they are ready to take in the knowledge. Some people aren't ready to learn. So we need to make sure that we aren't just spilling out information. They should be ready to learn and they should want to learn. And that's when we should teach them, because they're not going to be paying attention if they don't really care about learning. Something that they can get is called HIV-associated neurocognitive disorder, called HAND. And this is when they could have mental status changes, difficulties in concentration, memory, loss of motivation, irritability, and things like that. They could also have body image changes based on, their body's really changing. They could have a lot of weight loss and things like that. They might develop, like I said, the Kaposi sarcoma. So there's a lot of problems, okay? And all of the interventions are related to the manifestations, right? So improving their nutritional status, okay? Decreasing the sense of isolation, right? Because some people, when they hear, oh, you have HIV, they might want to steer away from you. So we want to, talk to them about, okay, let's talk about preventative behaviors, getting more knowledge out there so we can decrease that sense of isolation or feeling alone. Okay, they might feel a sense of grief because once you get HIV and you are diagnosed, we could give medications to help prevent, like I said, that symptoms really coming out, but you can't prevent it from happening. So, they might feel a sense of grief, okay? And they will eventually die from it because it will get to AIDS, and AIDS is when they have all of those symptoms, the neurologic, the respiratory, the oncologic. So a lot's going to go on. We want to improve knowledge, okay, because we want to help prevent any transmission to the family, educate the patient, avoid sexual contact with multiple partners, making sure you're always using barrier contraceptives, and do not use IV or injectable drugs. Don't share needles, okay? That's how HIV spreads. Remember, through sex, through pregnancy, and through needle sharing is how we could spread HIV. We want to monitor and manage for potential complications, so adverse drug effects, and or HIV acquired neurocognitive um, disorder, and have them talk about any sort of body image changes they might be experiencing. And we also want to teach them about any community resources. Is there any questions?